I'd like to start by first thanking the organisers, particularly Dr. Mardikar, for the great privilege of being here, and the European Society of Cardiology for this invitation. I'm going to talk about this morning left main disease, the surgical perspective. I do have some potential conflicts of interest here. Clinically, as a cardiac surgeon, I think that for many patients with left main, CABG is still the best therapy. I was one of the 25 ESC-EACTS guideline writers on myocardial revascularization for both multivessel and left main disease, and I'm the chairman of the surgical committee of the EXCEL trial. Whenever we look at the relative efficacy of PCI or CABG in any situation, whether it's for left main, multivessel disease, diabetes, the one question we must always try and decide there are four important issues to consider. The first is, are patients enrolled in randomized trials typical of routine practice? And the answer to this is usually no. With the single exception of the relative all-comer syntax trial, the 19 previous trials of PCI versus CABG enrolled fewer than 10% of the eligible population. These were predominantly patients with low-severity coronary artery disease, but the results of these trials were then generalized to the whole population. The second issue is, what is the duration of follow-up? And I would argue it must be a minimum of 5 years, because the benefits of CABG in terms of improved survival, reduced myocardial infarction, and repeat revascularization continue to increase with time. And anything with less than 5 years follow-up should only be considered an interim analysis. The third thing we need to ask is, what are the syntax scores of the study population? If we have no syntax scores, we have no idea of the severity of coronary artery disease, and therefore we cannot recommend what is the best treatment. And the fourth issue we should consider is, did CABG patients in randomized trials receive optimal medical therapy? And I will show you that the answer to this is usually no. Indeed, in most trials, CABG patients received substantially inferior optimal medical therapy in comparison to PCI, and this leads to an increased mortality and incidence of MACE. Now, back in 2006, so almost a decade ago now, I gave this lecture, Coronary Artery Bypass Grafting is still the best treatment for multivessel and left main disease, but patients need to know. And in that lecture, I analysed at that time the 15 trials of PCI versus CABG that had been published in the literature, and I made the observation, you can see that at the bottom of the slide, is that although these trials in total included almost 9,000 patients, this was fewer than 5% of the total eligible population. And when you look at the patients in the trials, most of them actually had 1 or 2 vessel coronary disease. Only 40% had proximal LAD disease. And they were therefore very different from the patients that we were operating on at that time, of whom more than 90% had 3 vessel disease and over 90% had proximal LAD disease. So although these trial patients were very different from those in routine practice, the results of these trials, which claimed to show no difference between PCI and CABG, were then generalized to the whole population. Now, if we look, before we turn to left main, what do we know about multivessel disease? Here the evidence is very clear. I could show you numerous meta-analyses, but I'll show you this single one published in JAMA in 2013 by Sapahi and colleagues, who looked at 6,000 patients undergoing either PCI or CABG for multivessel disease, and you can see that there was a clear reduction in mortality, both clinically and statistically significant, in favour of CABG. But it wasn't just a reduction in mortality. These patients with multivessel disease had a very significant reduction in myocardial infarction, the need for repeat revascularization, and note, there was no difference in the incidence of stroke in multivessel disease between CABG and PCI. If you look at the single most influential trial, the syntax trial at 5 years in patients with 3 vessel disease, this showed that CABG resulted in a marked reduction in death, cardiac death, myocardial infarction, and the need for repeat revascularization, and there was no increased incidence in the risk of stroke. And we shouldn't be surprised by these results, because if we look at the literature over the decade preceding these, this study, we can see that there was a consistent advantage of CABG over PCI for patients with multivessel disease. And if we divide this cohort into the severity of the disease according to low, intermediate, or high syntax scores, we can see that it's only in the low group, that's those with syntax scores below 23, where there is no difference between mortality in terms of CABG and PCI, but even in the low-risk group, there is still a marked reduction in the need for repeat revascularization. However, if you look at in the 80% of patients who have intermediate or high syntax scores, we can see that at 5 years, in the intermediate group, there's a 7% survival advantage of CABG. In the high-risk group, there's a 9% survival advantage of CABG, accompanied by marked reductions in myocardial infarction and repeat revascularization. And finally, if we look at mortality out to 5 years, there's a very important observation that at 5 years, the mortality curves are still diverging in favor of CABG, suggesting that even at 5 years, we're underestimating the true benefit of bypass grafting. The other point I made was the importance of ensuring patients are on optimal medical therapy. And this is a study published in Circulation showing that in the syntax trial, both patients who underwent PCI and CABG received inferior optimal medical therapy, but this was far more pronounced in patients undergoing bypass grafting in terms of reduced antiplatelet medication, statins, ACE inhibitors, and beta blockers. And the authors showed that the substantially inferior optimal medical therapy in the CABG group resulted in increased mortality and MACE in bypass grafting patients. So let me, before I turn to left main disease, ask this question: what are the 3 reasons why CABG is such a survival benefit over PCI? And there are 3 reasons. The first is that anatomically, atheroma is mainly located in the proximal coronary arteries, and this has important implications for bypass grafting, because by placing the bypass grafts to the mid-coronary vessel, this has 2 effects. It means that the complexity of the proximal culprit lesion is irrelevant, and it means that over the longer term, bypass grafts offer prophylaxis against the development of future proximal culprit lesions. In contrast, PCI only treats suitable localized proximal lesions and has no prophylactic benefit against new disease. The second important difference in the treatments is the benefits of the internal mammary artery. Tom Lucier showed almost 3 decades ago in the New England Journal of Medicine that the internal mammary artery elutes nitric oxide into the coronary circulation, which reduces the risk of development of further disease. He also showed a decade later that, in contrast, placement of a drug-eluting stent in the proximal coronary circulation impairs re-endothelialization, causes downstream endothelial dysfunction, and creates a pro-thrombotic environment. And the third difference between the treatments is that PCI usually means incomplete revascularization, first demonstrated clearly by Hannon in Circulation in 2006, where he showed that in 22,000 patients undergoing PCI, almost 70% had incomplete revascularization, and the subsequent mortality of these patients depended and was correlated with that degree of incompleteness of revascularization. This has been more recently demonstrated again by Sorois and colleagues in Circulation in 2013, showing that in the syntax trial, those patients who were left with residual syntax scores of over 8 increased mortality and MACE. And I would argue that it's for these 3 reasons that PCI will, for most patients with multivessel and left main disease, not be able to match the results of coronary bypass grafting. It didn't with balloon angioplasty, it didn't with bare metal stents, and it hasn't done so with drug-eluting stents. Now, if we turn away from multivessel disease and look at left main, we see a very different situation. So back in 2008, I co-authored this paper with several colleagues from Europe and the United States, where we looked at all the evidence in the literature for treatment of left main by either PCI or CABG, and we concluded, reviewing all the evidence, that CABG should remain the preferred revascularization treatment in good surgical candidates with unprotected left main. And we based that on 2 basic pathophysiological observations. which were that up to 90% of left main lesions were distal or bifurcation, and these were known to be at high risk of angiographic restenosis. But even more importantly, that up to 90% of patients with left main also had multivessel coronary artery disease, where there is already a survival advantage of bypass grafting independent of the presence of left main disease. However, in that study, we also did point out this paper by Tafo and colleagues looking at the favourable long-term outcomes after drug-eluting stent implantation in non-bifurcation lesions. And this group looked at 790 left main, of whom around 20% were non-bifurcation lesions. And treating these non-bifurcation lesions, there was a single in-hospital death, and at 73% of the patients underwent repeat angiography at 6 months with a single restenosis. And at 2.5 years, the mortality was only 3.4%, and only 5% of patients had undergone repeat revascularization. However, the authors did also point out stent thrombosis could not be excluded in the 4 patients who died of unknown causes. If we now turn to the Syntax trial at 5 years in the cohort with left main, here we see a very different result from what we saw in patients with 3-vessel disease. Now there is no difference in MACE, death stroke MI, or all-cause death between CABG and PCI, but the major differences were that in fact now there was an increased incidence of the risk of stroke. It was 4.5% in patients with CABG versus 1.5% for PCI. And the only benefit of CABG in this cohort of patients was a significant reduction in the risk of repeat revascularization. So I would again emphasize we see a very different pattern of outcome for left main from what we saw for patients with 3-vessel disease. And the authors again pointed out that the CABG patients had received substantially inferior medical therapy. If you look at the pre-combat study by S.J. Park and colleagues from Korea, they again found a similar result to the Syntax scores at 5 years. Now, in their study of 600 patients, the mean Syntax score was only 22, so a relatively low-risk population with left main. But again, they showed absolutely no difference in overall death, myocardial infarction. Interestingly, they found no difference in the incidence of stroke between CABG and PCI, in contrast to what we saw in Syntax. And they also showed again that there was a marked reduction in the need for repeat revascularization in patients undergoing bypass grafting. And again, they pointed out this was despite substantially inferior medical therapy in the CABG patients. Now, if you look at the main or the predominant analysis of left main coronary artery disease is by Thappan and colleagues, published in 2013 in JACC Cardiovascular Intervention. They looked at 24 studies, including 3 randomized trials with over 14,000 patients, and crucially, the patients were followed to 5 years. What this showed was that out to 5 years, there was absolutely no difference in the incidence of mortality between CABG and PCI. In terms of myocardial infarction, there was an increase with PCI over the first 3 years, but not the latter 2 years. In terms of target vessel revascularization, it was substantially increased with PCI throughout the 5 years of follow-up. But crucially again, they also showed the difference in the incidence of stroke between CABG and PCI. At 1 year, for PCI, it was 0.8% versus 2.8% for CABG. And as we follow these patients out to 5 years, that difference was maintained, 1.7% for PCI versus 4.7% for CABG. And again, I would emphasize this point, that these results that we see in patients with left main are different from what we see in patients with 3-vessel disease, where CABG significantly reduced the incidence of death, myocardial infarction, and repeat revascularization, and with no difference in the incidence of stroke. Again, this meta-analysis showed that where CABG is best is only in those patients with the high tercile scores. That is for left main above 32, where CABG reduces death, MI, MACE, and target vessel revascularization. And this is also very similar to what we saw in the Syntax trial for left main at 5 years, where with Syntax scores below 32, there was no difference in overall MACE between PCI and CABG out to 5 years. But in those with scores above 33, meaning those were the patients who almost certainly had significant additional proximal coronary artery disease. There was a major benefit of bypass grafting. So we asked the question then, what is the difference between left main and three-vessel disease? And the probable explanation for the difference is that if you have left main without additional three-vessel disease, there is probably too much competitive flow for bypass grafts to do well. Now, this is being addressed in two trials which we'll report later this year. The Noble trial, which has recruited 1,200 patients, and the XL trial, which recruited 3,600 patients as a proposal. In fact, what happened in XL was there were 1,000 registry patients collected quickly, but in fact, whereas there should have been 2,600 randomized patients, the recruitment was stopped in March 2014, where only 1,900 of the proposed 2,600 patients were recruited. And the tragedy for this trial is that whatever it shows, it means that the FDA will not approve the use of this stent from left main in the United States because the trial failed to recruit the patients that had been proposed. What else do we know about left main? What about the importance of location? Ostial mid-shaft versus distal left main. If we look at the Delta registry published in JACC 2013, we can see that at a median of 3 years, there is no difference in death or MI, but with distal left main, there is an increased incidence of MACE and an increased incidence for need for repeat revascularization. If we look at the effects of diabetes in left main, we see a similar effect to what was seen in the Freedom trial, which is that if you compare CABG to drug-eluting stents, there's a significant reduction in death, the need for target vessel revascularization, and the incidence of stroke in favor of bypass grafting. If we look at the effects of gender, again from the Delta registry, this looked at 350 propensity-matched females at a median of 3.2 years. And what you can see is that if you have CABG rather than PCI, even although the CABG patients had higher syntax scores, they tended to do better in terms of all outcomes, in terms of death, MI, freedom from MACE, although these did not reach statistical significance in relatively small cohort of patients. More recently, if we look at what is the importance of whether you completely revascularize, partially complete, or incompletely revascularized patients. This is a paper by Zhang and Patrick Sorois, published in Neurointervention in 2016, January this year. And what you can see is that if you incompletely revascularize patients, as we've known for the last decade, this leads to a very significant increase in the risk of all-cause death, cardiac death, myocardial infarction, repeat revascularization, and it even affects the likelihood of definite or probable stent thrombosis. And again, not surprisingly, it significantly increases your overall risk of MACE. So CABG for left main, can we operate on all patients with left main? And the answer is yes. And how should we do this? Well, it depends on the type of left main, because there is left main and there is left main. So if we look at this first angiogram, here's a complex left main equivalent. This patient would have a high syntax score, and this patient would do very well with coronary bypass grafting ×3. And because of the severity of the proximal lesions, this patient would be ideal for complete arterial revascularization because there would be little competitive flow. But if we look at this patient with an ostial left main, what would we do in bypass grafting? This patient would have a low syntax score, so we know that out to 5 years, there would be no difference in outcome between PCI and CABG. But if the patient was to go for CABG, how many grafts should we do? Would it be 1 or 2? And would we use arterial grafts when we know that there's a very high risk of very significant competitive flow? So the first angiogram is much easier to treat with bypass grafting, where you'd be far more certain of results than compared to the second angiogram. So what do the guidelines, the European guidelines, say for left main? So if we go back to 2010, for all categories of syntax score, CABG had a class 1A recommendation. For PCI, it was only with left main syntax less than 22. There was a 2AB recommendation, meaning that you could probably consider PCI. With the results of the syntax trial at 5 years, things have changed. If we go to the 2014 guidelines, CABG still has a Class 1 recommendation for all levels of syntax score, but notice the level of evidence has been downgraded from A to B. For PCI, for left main syntax with scores less than 22, it is now a 1B recommendation, so exactly the same as bypass grafting. But note also for the patients with syntax scores above 32, and that still accounts for 2/3 of all patients with left main disease today. Note that it still has a Class 3 indication, meaning you should not do PCI in these patients unless they are unsuitable for bypass grafting. So if I summarize and conclude, the first thing I would say is the previous concept that left main is exclusive surgical disease is no longer viable, and the syntax and pre-combat studies at 5 years have shown this to be the case. There is a definite difference in the outcomes between CABG and PCI for patients with multi-vessel disease versus left main disease. CABG does remain the best treatment for 2/3 of left main disease, that is those with patients with syntax scores above 32, and these results have been shown to be markedly better despite these patients having received substantially inferior optimal medical therapy. In left main, the benefits of CABG may be greater in distal lesions, in females, and in patients with diabetes. There is again consistent and robust evidence that the completeness of revascularization is crucial in left main disease. What we also now know is PCI may produce superior results in isolated ostial and mid-shaft left main, and especially in patients with syntax scores below 32. And the likely difference between left main and multi-vessel disease is that if you have left main without additional proximal coronary artery disease, this may result in excessive competitive flow for bypass grafts. The definitive answer to the best treatment of left main with syntax scores less than 32 will come from the EXCEL and NOBLE trials, which we'll report later this year. On that point, I'm going to conclude my talk. I would like to thank the organisers for the privilege of being here today, and you, the audience, for your attention. Thank you.